Good morning, ladies and gentlemen, and thank you very much for the invitation here to Berlin to this virtual forum about resilient healthcare systems, a very important topic indeed these days. And I was asked to give the keynote in about how the European healthcare systems have dealt with this crisis. So the essential modules that we see here, so if we talk about how they dealt with it, so what are the different modules they use? So the first one would be the testing. So everybody's talking about testing. And you may remember that in March, people didn't talk about testing so much, and it was the other way around, as you see it on this slide. So I am going to mention some further things about this. So there are other elements that play into this. So how do we test? What prerequisites do people have to fulfill in order to be tested? Then how these systems dealt with this was very different in France, for example. You only had testings in the hospitals, so 90% of the testing were done in France in the hospitals. At least in the initial phase, and we will later see the consequences of that. Then the capacities. How many patients can I test? How many people can be tested, and how do they get the results of their tests? So what do they do while they're waiting? Are they in quarantine, or can they walk around on the streets? And on the right-hand side, you see a diagram. I won't be able to go into all the details. Our organization started very early on in March already to look at the policy responses of the countries of the European Union, and we are evaluating these approaches, and we can also talk about the policies behind these approaches. And this was what led to the diagram that you see on the right-hand side. And in this case, it's how the countries dealt with the testings. And the second question that we have to ask is, where are people treated? What would be the first point of contact for a patient, especially connected with the first point, of course, with the first item. So if I have the testings only in the hospitals and people wait for the results of the tests in the hospitals, then it's logical to conclude that the treatment will also be done in the hospitals. So if you look at this together, then you ask, so who is responsible for the treatment? When do you have to transfer somebody somewhere else within the different departments of the hospital or in to the UC, the intensive care units? And there are other countries where you wouldn't have expected. Denmark, Norway, for example, had a similar approach, which was surprising. And here you see the diagram. So until the end of February, this is what we did in Germany too. And the settled physicians were told that the patients were going to wait for their results at home, and then with a positive result, they would have been transferred to the hospitals. And that would have led to congestion of the hospitals. I'm very happy, of course, that this wasn't the case and that this diagram was changed. And the third item, which was very much discussed at the beginning, was the relevance of the stationary, especially the ICUs, the intensive care units. and we didn't have very promising data. I remember telephone calls with people, and I was asked, if you don't know how many ICUs we have in Germany, then who does? And then we did learn things. We learned that we need an overview. How many ICUs do we have? How many ventilators do we need? And we could have known that before in Scandinavia, for example, in the Netherlands, in Great Britain. It is very normal to control exactly how many ICUs are available in the Scandinavian countries. Every ventilator has a specific number, and you know exactly where these ventilators are and and if they are connected to a patient. Very important also, and I started with this very early on, is in this chain of important questions is the question, what happened in the different countries? Let's start with Germany. So at the end of March, beginning of April, today, the population, we are all virologists now, epidemiologists. Some people may be a little bit confused about this development. I used to think in hundred thousands of people. So how can we compare to France, for example? The best thing would be to think in units of 100,000 people. That makes things comparable and much more easy to understand. And at the beginning of April, when we were at the peak of the first wave, we had 7 infections per 100,000 people. We didn't express that then in 100,000, so that was 6,000 per day. And that's exactly the critical limit, the critical threshold we have now too. And how many tests did we realize? How many people have been tested in order to discover one positive person? 14 to 1. So that would be 7%, would be pretty high today. But then that was a very good figure in the European comparison. And then the transition into the stationary treatment in the hospitals. How many people are treated in the hospitals? How many of, or what percentage of the infected people? 20%. It was then, that was a little more than 1,000 per day. Now we know from the evaluations that we did with the AOK data that people on average stayed 2 weeks in the hospital, pretty much like the other countries. And then in the ICU, and there's a difference whether you look only at those ventilated ICUs or just ICUs. And then we have a fifth, 25%. Then, and in the DV register, it's more, because they count cases. So they count from, if you go from intensive care to normal back, then you have 2 people, so you count them twice. So you shouldn't count these people as one person rather than one case. And a fourth, rather a lot, were transferred during the treatment with the ventilator, and unfortunately, a rather high percentage of those died, 0.1%, 0.45%. And then it's interesting also that most people in Germany died in the hospitals. There's difference to other countries where we had a lot of people dying also in the homes, in the care homes for old people, for the elderly.
So how does that relate to hospital capacities? And here I must say that a very important factor, as I said before, is If you calculate here 1 to 5, or it means 4 out of 5 were not in hospital, and with or without serious symptoms, they were treated in outpatient clinics. In other countries, it was different. I mentioned France and Italy. We always think of Italy when we looked at Bergamo. It was not Italy. It was very localized, but it was Lombardy. You will see in a few minutes, Italy, they have got a regional health systems. Italy has got 21 health systems, and what we have seen was just one region, Lombardy, and here 50% were treated as inpatients in hospital. Meanwhile, we know how many admissions there were, 1.4 out of 100,000. They were there for 7 days. So 3% of all beds at the peak of the first wave were occupied. We got the figures from EDEC. Till the end of May, it was 1.7% of the beds in Germany.
Das jetzt auf die Intensivbetten.
So, looking at the ICU beds, at the beginning we had 35, now rather 40 out of 100,000. And if you calculate that, at the peak there were 4 out of 40 were occupied, that's to say 10%, until the end of May, 4%. Until the end of May. I brought this along for those who want to have a closer look at that afterwards. That's the situation at the end of May. 2.5 months, 182,000 tests, 35,000 hospital treatments. We have also seen ENEC numbers, 7,000 were ventilated and 8,500 died. What was in those days? And here we look back at the first wave, first half of April. What was the situation like in other countries? And these are important comparative numbers. I said earlier on 14 tests per one positively tested person. So in those days, there were countries where more tests were done. In Norway, more than 20. Italy 4-1, France 4-1, Spain 9-2. That is to say 1 out of 4.5. That is to say there are higher numbers of positively tested ones, which means that this threshold of testing was much higher. So they focused on symptomatic persons, and not all the contact were traced, and often tests were made in hospitals. And my suspicion is, we are going to see that in a minute, that some who went into hospital, even if they had been negatively, at the latest when they entered the waiting room, they were positive once they were ready to be treated. This needs to be critically mentioned. This figure is a benchmark, rather. Of course, the hospitals are the outpatient facilities. They don't only have to do with the health system and its organization, but also the total number. But we see on the one hand, this is an important figure, but on the other hand, the strategy of health systems is much more important. So as I said, we had 7 out of 100,000, as many as France and the Netherlands. Now, as to say, in September. So, but in those days, in red, Spain had 70 and Italy, Lombardy 21. So now 20% of the people were treated as inpatients, were admitted to hospitals, because in those days the hospitals were the first contact and tests were taken there. Then over a long period of time in France, 2 out of 3, that's to say 70% of all positively tested persons in France were admitted to hospital, and with the same intensity as here. They stayed in hospital for 2 weeks as well. That's to say they were not lightly ill people. So Italy, you must never speak of Italy. I mentioned a few regions, and they are very different. Bergamo, everybody looked at Bergamo, Lombardy. Where also all the development and help assistance package were geared to to 5, a few kilometers further east, belonging to the region of Venetia, a similar epidemiological structure situation, but a different health structure. They had successively introduced health centers, opening hours of 10 hours up to 14 hours, from 8 till 10 in the evening, 8 in the morning, and a few kilometers away from Bergamo, 5-1, the same figures as in Germany. Only 1 out of 5 were taken to hospital. And then the intensively treated patients, you also have to see them in relation to the total number of people treated, and that were in most cases fewer than here. So flattening the curve, that was very crucial behind that we wanted to we only looked at the hospital capacities. Nobody else rather talked of anything else, only about hospital beds. That's what I did here. What we wanted to flatten was this curve. I show it to you. From mid-March till the end of August, you see the used hospital beds in the various countries. The black curve is the number of used hospital beds, and the orange curve is the number of available hospital beds. Therefore, you see these straight lines, and you see the maximum use was 20% of hospital beds in Italy. And in Italy has rather a small number of hospital beds. 1 out of 6 were used. Here in Germany, we rounded the figures. 1.7% of the beds were used. 1/50th. 2%. In Germany, it's not shown here, but 1 to 50, and that is to say the black curve in Germany would have almost been completely flat. You could do the same for the ICU beds that rather focus. So through the European Observatory research, we also found how many percent of beds were added in the ICUs. Previously, you see the red line. That was the previous existing number of ICU beds, and the additionally added beds are shown as dotted lines. The Netherlands, they have more than doubled their capacity of ICU beds. So Germany is shown here. We used to have 33 to 34 and later 40. And you see here that's the same scale. And you see here also the situation in the Netherlands. Here you see Lombardy. In Italy, the whole of Italy is shown here to the left, and here Sweden and Netherlands. And you see that in these 3 regions, respectively countries, the previously existing ICU beds would not have been sufficient to ventilate all the patients. They really needed the additional ICU beds in order to ventilate the patients. In most other countries, even in the UK, we have seen that there is a high curve going up to 60% of the ICU beds that were used, but not exceeding 100%. In France, with the many patients, there were a similar number here. Norway, Greece, or Finland. Also, the burden on the ICU beds was not as strong as expected. Denmark was also shown here. This can also be expressed in cumulative numbers. So, for example, here you see how many bad days per positively tested COVID patients. How many beds did we need? Hospital days. How many people were admitted? If in France 2 out of 3 are admitted to hospital and they stay in hospital for 2 weeks, then you can see that it is a higher value. You see it also here in France at that time. They assumed that per additional case identified, there would be 12 hospital days. It's to say an extremely high use of resources per case in most countries. The value was between 2 and 3 days. You can see it here. 1 out of 5 stayed in hospital for 2 weeks. So on average, it was about 2 to 3. But you see here in France and Lombardy, Italy, Belgium, the UK, Netherlands, they have high numbers. And then the ICU days per case. France was not overwhelmed because they have more ICU beds than the Netherlands or Sweden, but they made a lot of use of ICU beds. So we had 2 ICU days. In France, it was 2 ICU days in France, and we were at a range of about 0.7, and this was similar to other countries. So the most important figure that was much discussed at the beginning, now it is not that much in the focus anymore. That is the excess mortality. Excess mortality, meaning in comparison to other normal years, how many people died. And this hasn't got anything to do with with people having died from COVID, but they can also have died from other diseases because the hospitals were filled to the limit, and the other diseases could not be treated correspondingly. So have a look at the percentages. These are the percentages until the end of August in most cases, but here the percentage at the peak of this wave, for example, here in Spain, were much higher. But all in all, in Spain, until now, 26% more. Italy, Great Britain, 24% more. And then there are countries which have no excess mortality: Germany, Denmark. And then you can have a look at the absolute numbers. In Spain, there were 50,000 more who died. In France, 26,000. So, and this needs to be compared to the COVID fatalities. So the question is, are those who died really COVID fatalities? And both France and Spain, they reported 30,000 COVID patients. In France, this matches. That's to say, there are more than those who died from COVID, but in Spain, 20,000 are missing. So then the question is, were the COVID patients not properly assessed, or are these patients which, due to the overwhelming of hospitals or doctors and physicians, died from other reasons? This needs to be given further attention. What do we learn from this European overview? Very importantly, and yesterday we opened a congress of the supply facilities, and they said it is standard today. Testing is very important, also outside hospitals. If test stations are only in hospitals, that was a false strategy applied by some countries. That must be said honestly. And what also has become clear is that public health service, in particular when it comes to the assigning of responsibilities from the healthcare system to municipalities. Many think of the state health system. But in the UK, the national health system, the NHS, is completely decoupled from the municipalities. The NHS has got its own structures, and so far there is no data exchange between the municipalities and quarantine measures and the health service. So to keep patients as long as possible away from hospitals, I think that was also our success factor, because hospitals are dangerous places, not only in pandemics, but also in other times. And everybody who does not have to go to a hospital should not go there. So the Ernst von Bergmann Clinic in Potsdam, one hospital in Potsdam nearby, is a special case where 47 patients died, and out of those 47 people, only 3 were hospitalized because of COVID. 44 have got infected during the hospital stay, and out of 138 nosocomial infections. I'm sure that this is similar in Italy. Research is also done into that, and I'm sure that in other countries, actually this explains part of the disaster that happened. It needs to be clearly said here, looking at these figures. So patients, they were smart enough, they knew that. Well, we thought, well, there was there's a benefit given to hospitals to keep capacities free. Mr. Spranes, the Minister of Health, also thought so. And it was believed that hospitals would postpone elective surgeries or treatments so that the ventilators, etc., could be used. Here, figures from INEC, they need to be doubled because they only reached till the end of March. Hip prosthesis, first implant, there were 50% fewer than in the previous years, but diabetes mellitus, actually, that is an ambulatory condition that minus 19%, often in diagnosis where a patient with the potentially referring family doctor, well, they rather refrain from going to hospitals than one would have thought. Then there was the debate whether cancer patients were not cared for. We really had looked at that pancreas carcinoma plus 9%, but there were some where there was a slight decrease. But often it is said, well, these cancer patients were not treated. We normally treat cancer patients 4 times in hospital, and if there is a slight decrease, then it would mean 3.6 times. So hip fractures and hospitalizations plus minus 0%. Means, and we also have this debate in other countries, that there would have been fewer hospitalizations. So 1 out of 3 hospitalized patients in Germany would not have been hospitalized in other countries. So now for the first time we had similar figures, but the important point is to look where these patients, and that's what we do by the expert council of the evaluation of COVID, and the next data wave is approaching. We can tell you more in a few weeks from now. That is actually what I wanted to tell you about what the situation is in Germany. How can this be structured systematically, from testing to treatment and ICU treatment? What is our condition? What can other countries learn? And I told you at the beginning that we update these country reports daily. Also, the 53 countries in Europe and in WHO, and there are also cross-country studies that you can read. Thank you very much for your attention.